I'm Ulrich Sidney, the President of the Association of Future African Neurosurgeons and a Research Associate at the Program in Global Surgery and Social Change at Harvard Medical School. Today we have yet another session of our webinars, and we have a fantastic guest speaker today. I'll be presenting right after we present the panelists and attendees. So first up, we'll have David Ulrich Dale. Can you please unmute your mic and present yourself, please?
Okay, hi everyone. I am David Ulrich Dale. I'm a medical student first year in Russia, and I'm equally member of the operation and communication team of AFAN. I'm really glad to be here today. It seems really interesting this afternoon. Thank you very much.
Well, thank you, David. And then next up, we have Ndale Genevieve. Ndale, please unmute your mic and present yourself. Seems like she has troubles with that. Okay. Femi Daniel. Femi Daniel, can you please unmute your mic and present yourself?
Yeah, hi. Good afternoon, Douglas. Good afternoon, Sydney. Good afternoon, everyone. Femi Daniel is a neurologist in Lagos. Hi. I can see you waving, Douglas. It's good to be here, all right? And I hope to hear your feet, all of that being shared with everybody today. Thank you.
Wow, we always love to have the neurologist around, the smartest people in the room. Thank you, Dr. Femi. Next up, we have, Gideon. Gideon, please unmute and present yourself.
Hi all, my name is Julian and I'm a fourth year medical student in London, United Kingdom. Good to be here.
Thanks, Gideon. Lorraine Sebopelo.
Hello, everyone. I'm Lorenzo, a third year medical student from the University of Botswana, and thank you for having me.
Thank you, Lorraine. Next up, Neontle Akaiwa.
Hello, everyone. My name is Neontle Akaiwa. I'm also a third year medical student at the University of Botswana, and I'm glad to be joining you as well. Thank you.
Wow. Thank you. Dr. Nuru. If you're speaking, we can hear you. Please unmute your mic. Okay, I think he has some issues there. Next up, Olawa Ezekiel.
Greetings everyone. I'm Olaoluwa Ezekiel Dada, a second year medical student from the University of Ibadan. I'm happy to be here.
We're happy to have you too. Okay, so I think the other panelists don't have their mic turned on, so we'll go straight ahead and present our guest speaker today. Dr. Douglas Okor is a consultant neurosurgeon and CEO of AshantiGraham Medical Company Limited. He's a subspecialist in skull-based neurosurgery, endoscopic pituitary neurosurgery, neurovascular and complex spinal surgeries, a really accomplished and complete neurosurgeon. And he leads a fantastic team that delivers complex neurosurgical care at the NISA Premier Hospital, Garki Hospital, and Citadel Medicals and Diagnostics. And all of these are in Abuja, Nigeria. Dr. Emeka Okor is the foremost Nigerian health sector advocate. He's an entrepreneur, a motivational speaker, and a youth empowerment mentor. His secondary education and primary medical degree were done in Benin City at Adolo College and University of Benin, respectively. His specialist medical training was in the United Kingdom, where he rotated through and spent time in 10 of the 31 neurosurgical units in Great Britain. Dr. Okor is also a co-founder and chair of the AshantiGraham Health and Education Initiative Foundation, a charity with a vision for 21st century healthcare for Nigeria. We're so happy to have you today. Please unmute yourself and start sharing your screens, Dr. Douglas Okor. Thank you.
Thank you very much, Ulrich. I think I've unmuted myself. Can you see me?
We can see you and we can hear you loud and clear.
Okay, good. Once again, thank you, Ulrich, and thank you for everybody who was tuned in to actually listen to me speak about what neurosurgery is all about in Nigeria. Like I said, thank you, Ulrich. I think you muted yourself. That's me. You've actually introduced me. I actually did my medical school in Nigeria, and when I was in my fifth year in medical school, I decided I was going to become a brain surgeon, because in the university where I trained all the way from the mid-70s, when that university was established, up till the late 90s, when I was in my fifth year in medical school, there was not even one neurosurgeon. And at the time when I decided that I wanted to become a neurosurgeon, there were only roughly about 10 to 14 neurosurgeons in the whole of the country at that point. And I think that the country had a population of roughly about 140 million people then. Over time, things have actually slightly improved in terms of the numbers. I think presently in Nigeria, we're looking at roughly about 90 fully trained neurosurgeons, but now we have a population of about 200 million people. Any specific questions you have, Ulrich, or do I just continue?
Wow. I think it's up to you. If you like, we can either interrupt with the questions, or we can go. We can let you go ahead all the way.
Yeah, that's fine. I can go ahead all the way. So basically, we are talking about complex neurosurgical service in Nigeria, where we are today, the issues in terms of what the deficiencies and the major and the problems that we have, what we can do to solve these problems, what the present state is, what the realities are on ground, and what the future holds, especially when I'm really grateful that you have relatively young people in medical school, really young people, residents on this platform, because you guys are actually the future of the African continent. One of the things I tell people, especially those in healthcare, is that mainstreaming progress on the African continent, be it Nigeria or any other African country, depends on the mindset of people like you. Okay, of course, most will ask me, why did you train to become a brain surgeon in the UK and actually go back to Nigeria? For some reason, my decision to actually go back to Nigeria, I actually made that decision before I even left Nigeria. My plan was always to go back to Nigeria. And so when I arrived, because I arrived in the UK in 2006 to pursue my dreams to become a neurosurgeon, and one of the first things that hit me, two things hit me actually. One of the first things that hit me was that in places like UK and Europe, it's not that they have heaven and earth. But they are just very strategic in terms of the way they plan their life, in terms of the way they focus on things. And I saw that, for example, back in my country, the most populous country in Africa, a sleeping giant. That's what I describe my country as, because my country has massive potential. Every country in Africa has potential. But I saw that one of the major problems that we have was the human beings with the right mindset. Okay, and I think one of the key things I want to push out here in terms of how we can actually move forward in Nigeria or other African countries is the mindset. We need to really work on our mindsets. It's really critical. So that's one of the first things I noticed. The second thing I noticed when I actually landed in UK was that the respect that the way I was looked upon by the average person in the UK, especially the white guys, was that I knew that they didn't have respect for me. And I knew that the reason why I didn't have that respect was because of the way they looked at where I came from, the kind of things that happened, the way things are being run in my country and all that. And then my zeal to actually go back to Nigeria was reinforced. You understand? It became even stronger. Okay. Now people ask me, why would you leave UK where you probably have a better life? You probably have the kind of hardware, the kind of system, the kind of teams that will be able to help you actually provide the kind of care that you want and stuff like that. And in my mind, one of the things that I always say is that I know that I've been given a job to actually play my own role in terms of raising the bar and raising the standards of what care can be in Nigeria and by extension Africa. And I've dedicated my life to that. And that's why, despite the fact that I'm back in Nigeria and with all the significant difficulties that I and people like me that face, I can say with significant pride that despite those difficulties and those inefficiencies and gaps in our system, I can say that even within my own small area of influence, you can actually see changes and things actually happening. So I moved back to Nigeria in 2016, August 2016, and initially I was flip-flopping. So initially I was spending maybe a few months in Nigeria, in Abuja, and a few months back in the UK here. But I decided finally in May 2017 that, hey, I cannot speak myself. If I want to be really committed to actually changing the narrative on the ground in Nigeria, I have to actually put myself fully into it. And of course, at no particular time at all, Ulrich and audience and all the guests, at no particular point in time at all did I ever feel or think that it was going to be just very easy and a walk in the park. At no particular point in time. Same thing with even when I left Nigeria. When I was leaving Nigeria, I remember I was in the kitchen one day with my mom, and because then I was working in the teaching hospital where I was trained as well. I was working as a medical officer, working in the HIV unit then. I was the pioneer medical officer then with one of my colleagues, then Tony. And then my mom asked me, oh, but you have a job in Nigeria here. Why are you going to the UK? Who do you know in the UK? And I told my mom, I said, hey, Mom, I know that my going into the UK is not going to be a walk in the park. I'm going to have mega difficulties as a black man, you know, so with this, my funny accent and everything, and my strong-headedness and all that, I'm going to have difficulties. But I'm telling you, in the long run, we're going to smile. And my training in the UK, I went through the mill. They always ask this question, how do you make steel from iron? You put it through fire, isn't it? I went through significant fire in the UK, okay? And funny enough, I was trained very, very well. One of the things I found when I got back to Nigeria, because my personality, you never ever see me wearing suits. Most consultants and senior clinicians, they like wearing suits to show that, hey, you know, we are the big guys and stuff like that. But I don't do that. I always wear my shirt full, my sleeves, and then I'm always wearing jeans or cowboy boots and stuff like that. So one of the first things that happened when I got back to Nigeria was like, this young guy, are you sure this guy is a real neurosurgeon? And because of that, my personality sort of portrays things as if my coming to the UK was just a walk in the park and happy is very easy. But no, I was trained very well and I was put through the mill, I was put through fire, went through lots of difficulties during my training. And to tell you the truth, that actually prepared me for actually going back to Nigeria. And I'm grateful to all my trainers. Because like you said in the intro, I spent time in about 10 of the 31 neurosurgical units from the north to the south of the UK. And that was absolutely fantastic. What would I call it? Absolutely fantastic experience. Really, really great experience. Sometimes when maybe I'm talking with colleagues and they ask me, oh, have you used this particular kind of equipment before? And I say, yes, sir, I've used almost everything. Because, you know, as I went up and down the UK in terms of my training and stuff. So yeah, moving back to Nigeria, I did not think it was going to be a walk in the park. And nothing surprises me till today. So the question is, what are the difficulties? What are these obstacles, these inefficiencies within the systems in a place like Nigeria? And just to let everybody, and I'm sure everybody agrees with me, that this is replicated across most of the African countries, especially the countries in the Sub-Saharan, West Africa, East Africa, Central Africa. This is replicated across board. I guess it's a little bit painful in Nigeria because of all the potentials we have as a country, especially in Nigeria. Yes, the population, the landmass, and all that, but it's really, really painful in Nigeria. In Nigeria, for a very long time, more than 40 years, 45 years, we have been struggling with our healthcare system. And of course, it's not surprising when you have politicians and the political elite that for a very long time, and I'm sure that's replicated across most African countries, for a very long time, the issue of prioritizing and mainstreaming the value for human life as a major factor has been a problem. Has been a major problem. You have very selfish politicians, and funny enough, they're actually even selfish themselves. One of the things, anytime I'm speaking on TV or being interviewed on the radio, I tell anybody who wants to listen that, man, see, as a politician, a senator, a president, a vice president, whoever you are, once you have an emergency, that's what we call the golden hour. Once you have an emergency, if you do not have the capacity within your area to actually look after you. You're dying like anybody else. Whether you're like anybody else. All the money you start in banks in foreign will not help you. So even from a selfish point of view, the politicians should actually look at things from a selfish point of view and actually start really preferring solutions in real time to the issues of healthcare. Okay, there are three pillars. There are three pillars of any developed economy. Okay, and they are healthcare, education, and infrastructure. Okay, and for a very long time in the African continent, especially like I said, Sub-Saharan Africa, West Africa, Central Africa, and East Africa, the governments and the politicians have not mainstreamed healthcare. They have not, because they actually do not care about the people. So what are the issues? Okay, the issues are basically what we all know about. Should I bore you with that? We all know what the issues are. There's a lack of government commitment. Okay, most people have actually lost faith in the system. Okay, you look at things like funding for healthcare. Funding for healthcare is generally is abysmal. Okay, and like I said, it falls back to the key issues that most of the people in government don't actually care. Okay, they have a headache or so, they either fly to Germany or fly to UK or fly to the US. Okay, the people who are on ground in Nigeria, the lower economic class group, they can go die for all they can. Okay, now so neurosurgical care in Nigeria has suffered just the way other healthcare services have suffered as well, and same thing in most African countries. So neurosurgical care in Nigeria. Neurosurgical care, basically, I qualify it as quaternary care. You know, we have the different levels of care. We have primary, we have secondary care, we have tertiary care. So primary care is the first point of call. Okay, in Nigeria, the primary health system is broken. It's basically non-existent. Okay, it's a big joke. You have the secondary healthcare system where they're supposed to be dealing with a particular level of illnesses and medical conditions, and of course, you have the tertiary healthcare system, which is supposed to be like the where you actually look after patients with complex care needs. But there are two subspecialties in medicine that are actually described as quaternary care: neurosurgical care and cardiothoracic care. Okay, I describe them as quaternary care. They're even higher than tertiary care. Okay, so neurosurgical care is quaternary care. Now, in a country where even primary healthcare, that is the bedrock of any healthcare system, is in tatters, of course, you can extrapolate from that what the secondary healthcare and the tertiary healthcare and things like neurosurgical care and cardiothoracic care will be. We are in very big trouble. Okay, and so when it comes to the different issues, when it comes to the leadership and management to actually help build up this kind of services, it is lacking all the way from the Federal Ministry of Health to the State Ministry of the provincial ministries of health and everything. When it comes to the strategy, it comes to the issue of strategic communication, comes to the issues of actually building up services to actually have coordinated services. When it comes to pre-hospital services, emergency services, we are struggling. You might have things in name or have a building somewhere or something like that, but when it comes to on the ground, actually delivering that service that is patient-centered, okay, we are struggling. And so what now happens in a place like Nigeria where there's general lack is that you now have individuals trying to fend for themselves. Once the system is failing like that, you have individuals trying to actually fend for themselves. So when you look at the key issues of trying to push the boundaries in terms of the innovation, the creativity of the private sector trying to come in, when you look at things like what I call the CCP, where you're talking about collaboration, cooperation, and partnerships, it is a struggle because in a system like that, you have individuals struggling for their own. Okay, so you don't have people who are struggling, people become very selfish, people actually are focusing on what they can get because the system has failed. So one of the painful things is that while in terms of progress, significant progress is being made in the private sector in terms of actually having capacity when it comes to availability of complex healthcare services. Okay, but the issue of actually trying to scale up from the point of view of people actually pulling together and trying to coordinate things, there is a struggle because everybody is suspicious of everybody. Most people are very would rather be individual. Most will focus more on money than quality. And one of the major problems we are having in terms of capacity is the human resource for health. Ulrich and everybody watching, the human resource for health in places like Nigeria and other African countries is extremely weak. Extremely weak. Okay, and it's weak for lots of reasons. Number one, investment. Okay, there is no, you understand, proactive investment in building human capacity. None at all. And so what you find across board is a situation where people are just going through the motions, you know, and doing things that in their mind is training or building capacity, and then you're looking more at people actually having certificates and having names, say a consultant, neurosurgeon, consultant, physician, and different names. But when it comes to the real capacity to actually deliver care on the ground to the people and pull together as a team in terms of the multidisciplinary approach to them, it is a major struggle. And of course, like I said, because it's a setting where everybody has to fend for themselves and people have to struggle for themselves and everything, there's lots of individualization and people actually trying to get for them, pull for themselves and struggle for themselves. You now find out that that issue of actually focusing on the bigger picture of things and how we can actually pull together to actually develop things and actually scale up and all that, it is a major struggle, a major struggle.
Wow, thank you so much. Very, very powerful. I'll go with a first question. So how do you get the neurosurgeon operating room to think the way you do and come up with those solutions? How do you make that transition?
Okay, so the thing is, one of the things I always say is that you cannot give what you don't have, isn't it? You cannot give what you don't have. Now, for one of the fundamental problems we have on the ground is the issue of attitude. Okay, the issue of attitude. When you've lived in a place where there's where people are struggling, you get to a point where, you understand, there comes this very ugly competition. Do you understand? Because you're looking at an issue of scarce resources, isn't it? Scarce resources, competition, a political elite that are very selfish and they do not care about the people. So it's now every man for himself. And that is what affects attitude, isn't it? So you now have people who, when it comes to that issue of empathy, that's a very key word, empathy, or being able to step into people's shoes. The average, and I'm sure it is the same people in Africa, the average Nigerian has now become very selfish. Because the average Nigerian just looks out for himself. And so one of the things that sometimes people complain about the attitudes of healthcare workers, for example, in Nigeria, the doctors, the nurses, the physiotherapists, and say, their attitudes are terrible. But one of the things I tell them is that, but the doctor, nurses, and physiotherapists in Nigeria are actually Nigerians. How does the average Nigerian actually do understand? How do they act? What is their attitude like? If you go into a grocery shop, for example, to actually go buy something and receive a service, or you go to a hotel and you're receiving service, you go to an airport, you're receiving service. How does the average Nigerian who is working in this place provide service for you? And that's reflective, okay? So there's been a breakdown of that communal spirit of people trying to look out for each other, of people trying to work together, of people actually understanding the importance of service delivery at a particular level. Customer service and service delivery is very, very poor. And so one of the fundamental things, one of the things that I have done, like I said, in my small area of influence, is to start working on the attitudes of people. It's a major problem. One of the things I tell people is that anybody who wants to work with me, okay, I don't care of to tell you the truth, your knowledge base and your experience and stuff doesn't actually matter to me. What matters more is your attitude. Very critical. That's one place we are falling down really, really badly. So that's one of the first things I've done, the attitude. Where most of the places where I provide care, one of the general things that comes out is that people say, they don't like working with me. And you know what I always tell them? I say, if I was myself, I wouldn't like working with me either. And some people say, they don't like me. And I tell them, hey, my wife and my daughter and my son, they actually like me. That's enough for me. I didn't move back from UK to come and get love and to get people to like me. That's not why I came back. I came back because we are suffering as a people until we start putting together and actually using some initiative to start changing our circumstances. Nobody will do it for us. Of course, as Africans, we are very religious people. Everybody keeps looking up to God and stuff. Meanwhile, God has provided everything that we need is in our hands. But because of our attitude, terrible attitude, Okay, we are not able to harness all those things that are already in our hands and in our heads. Okay, so the first key thing to answer your question, Ulrich, is that the key thing I've done is to slowly start changing attitudes. And of course, how do you do that? The multiple prong approach. You fight, you're diplomatic, you beg, everything, you throw everything in. If you're passionate about it, passionate enough about it, you throw everything in. And that's exactly what I've done. Everything, you throw everything in. Okay, everything. And wow. one of the things I do, I'm a very pragmatic person. One of the things I tell people is that the average neurosurgeon who was trained in Nigeria knows more theoretical stuff than me. But when it comes to real life of implementing things, of being innovative, of using whatever resources you have on the ground to do the best you can do, oh yeah, because I'm blessed with that. Okay, when it comes to the issue of application of knowledge in real time, there and then, look at the issues confronting you here and there. Oh, I'm blessed with that, and I thank God for that. Okay, so attitude is a major problem.
Yes, thank you. I mean, from what you've said, we clearly see that a neurosurgeon today, an African neurosurgeon, needs to be well-rounded. You're insisting on what a lot of the researchers today will call the non-surgical technical skills, non-operative technical skills, and those are very important. All that you're talking about, that's the emotional intelligence, being able to know when to beg, when to fight, when to be diplomatic. I mean, those are extremely important, and I will invite anyone here to go and read about non-operative technical skills. Now, the next question comes from Gideon. I'll just add a little bit to it. His question is this: how do you think colleagues in high-income countries can best help the situation in Nigeria? Just adding to that is, I mean, as an African, we know that one of those countries that when you spoke about potential, I know of two big potentials in Africa: Nigeria and the Democratic Republic of Congo. Huge population, huge resources, very intelligent people. If you go around the world, I mean, in the US, there's so many Nigerian-born neurosurgeons. In the UK, so many Nigerian-born neurosurgeons. And I guess Gideon's question is, how do we tap into that diaspora? How does the diaspora try to help and change things in Nigeria?
Well, good question. I remember there was a day, you know, I post lots of all the things, or most of the things I do in Nigeria. I post them on different platforms. And I remember there's this platform where we have Nigerian doctors in the UK. And one of them told me, one of them stated and said, you've really undertaken something really mega here. I hope you do succeed. And my response to him was, I hope for your sake that I succeed as well. Because one of the major problems is this, you know, that Africans in the diaspora, okay, whether you're in Canada, in the UK, US, Australia, and stuff like that, guess what? Your cousins, maybe your mom, your dad, they're in Africa, isn't it? They're in Africa. And I told him, I said, man, for your sake, I hope I succeed as well. And well, you know, and that's another problem with us as Africans as well. Sometimes, especially us in the diaspora, it always looks as if things are just so far. No, it's not us. It's them. No, the day it happens to your own father or your cousin or someone, lots of times I get most of my colleagues in the UK. Guess when their parents or any of their family members in Nigeria have an emergency, especially if it's a neurosurgeon, guess who they call? They now remember, oh, thank God that Douglas is there in Nigeria. Okay, so what am I trying to say is this? It beholds on all of us. We are all part of it. You cannot exclude yourself, no matter where you are. That's the first thing. Second thing is that to actually make changes on the ground in Nigeria, Africa, you do not need to physically be on ground in Nigeria. Please let me state that very, very clearly. Okay, we are now in a global system. Okay, we are now in a global world. Okay, so you don't have to physically be on ground in Nigeria. Now, but you need, for the guys who are in the diaspora, you need a bridge, isn't it? Now, the best kind of bridges are people like Dr. Emeka Okor. They are the best kind of bridges. You know why? Because they were in the diaspora, they are now in Nigeria, they are understanding the Nigerian system, they work within the Nigerian and African system, they know how to actually bridge that gap. They know where for example, the guys in diaspora can come in and say, oh yeah, there is this gap, you can bridge this gap and something like that. I'll give you an example. One of my colleagues, Farouk basically did his secondary school, university here in the UK, and I think it was 2 years my junior in training. And at one point he was like, oh, he doesn't want to go back to Nigeria. And I told him, I said, no, you don't have to go back to Nigeria. Everybody cannot go back to Nigeria. But I would like you to actually make contributions to Nigeria. Now he's doing his fellowship in neuro-oncology. And then recently he sent me a message and said, oh, I would like to actually get involved with something in Nigeria. Now, guess what? One of the things he can get involved with in Nigeria is actually setting up a proper neuro-oncology service somewhere. And actually now and again, yes, I'm being involved now, multidisciplinary meetings, for example. Okay, our tumor board meetings and stuff like that. Okay, so one of the key ways, very key ways that the diaspora and people outside Nigeria can get involved is actually building capacity of the human resource for health. That is absolutely important, and we have the technology for that. Look at what we are doing now. You're in a different country. I'm here. I'm in the UK. Oh yeah, I just came to visit my family in the UK. I've not seen my kids for almost 9 months now. So I landed UK 2 days ago. But yeah, we're in different places, but we're doing this. Okay, so the technology is there. And I want to use this as an opportunity, you understand, to actually beg and plead on these people you talked about. You alluded to them, the Nigerians who are neurosurgeons in America and stuff like that. Please, you understand, please try and help us. Try and help us. You understand? But the key thing is that the work that people like me are doing is fundamental, because at least we're able to show that all the things that people thought that were impossible in a place like Nigeria and Africa, they can actually be done. And I've used myself, I've actually, I've thrown myself in the ring and actually done the work I've done for the last 3.5 years in Nigeria to actually show that it can be done. It is not all doom and gloom. Despite the inefficiencies, the gaps, I told one senior clinician the other day, we're having it, I think that was about 6 weeks ago, and they were having a discussion, and I think there was an issue with how a particular patient was managed in a facility. And this senior clinician was actually trying to tell me of the gaps, the inefficiencies within our system, and try to actually compare it to, for example, UK, where I'm coming from, and stuff like that, and saying that we have a broken system in Nigeria. And I told him, I said, see, you're more senior to me, you have more experience on the ground in Nigeria, because this senior clinician was also trained in the UK as well. You've been on the ground for much longer than I have. You've established things and stuff like that. And I appreciate you as what you're telling me in terms of the broken system in Nigeria. But I told him, I said, even with the small experience I had in Nigeria, I know for sure that despite all the inefficiencies and gaps we have in our system, we can do much better than we are doing now. Absolutely. There's no doubt about it in my mind. And I've proven it. I'm not speaking from, oh, somebody said. No, I have proven it myself that we can do much, much better. I'm saying that even with all the problems that we know that we have in places like Nigeria, in the Democratic Republic of Congo, in Kenya, you understand, in most of the African countries, even with those problems, we can do better than we are now and slowly start moving. So again, like I said, Ulrich, it's not all doom and gloom.
Oh, yes. So I think a great summary to that is we have to hold ourselves to greater standards, and we need to do more. I definitely agree with you. One thing I noticed is a lot of what you say, you said, goes around this concept of global neurosurgery. You basically deconstructed the health system, talked about the service delivery, talked about the workforce, all those concepts. And I in all the global neurosurgery literature today, a lot hasn't been said about that side. You're speaking about the role of locals. It's been always about foreigners and what they can do for low and middle income countries. And you've spoken about the diaspora. I find that very interesting. I think personally, this is something we needed. We've had these conversations with a few folks before, and I really appreciate what you're talking about, what you did. Now, for those who don't necessarily know what you've done on the ground, can you please elaborate on what you've been able to accomplish in Nigeria? And perhaps how can these young folks do the same like you, or help you, assist you in what you're doing?
Okay, so one of the first things that I'm sure we all know is that when it comes to the appreciation and the confidence in the healthcare systems in most of these African countries, generally the people don't trust what's happening within the healthcare systems in these countries. So, for example, in Nigeria, you have lots of documentation and articles that talk about the flight of money out of the country to other countries for what they call it, for medical tourism. of course, a major destination is India, for example, from Nigeria, and I'm sure most other African countries as well. And of course, the major thing for that is, hey, in Nigeria, we do not have the capacity to actually provide a particular level of care. Talk less of any level of care for that matter. Okay, so one of the first things that one of the things that really pushed me, apart from the fact that I decided to go back to Nigeria for a long time, was, hey, I am not respected in the UK because the way they look at me is like, okay, you ran from your country, you came here to get a better life and stuff, but you ran from your country because your country is, forgive my French, shit. You know, so you come to this country. So one of the things that really pushed me and really, you know, gave me that oomph to actually want to come back was to prove to the world that meant despite how weak our systems are, we can still do stuff. We can show the world that yes, we can do this. You know, there's nothing you people are doing in the UK or in the US that is rocket science. We can do this. Okay, so that's one of the cases that really pushed me. So I came back on ground in Nigeria. I joined one of my colleagues who actually trained in the UK as well. Actually trained me during my early days in training. His name is Biodo Ogumbo. And so I joined him at one point. And then one of the key things I met was that when it comes to the appreciation of the capacities that we actually have in Nigeria, the average Nigerian does not know what those capacities are in Nigeria. They are what they call the 3 A's of healthcare in terms of availability, affordability, and accessibility to care, isn't it? And so the first thing I now thought was that one of the things we need to do is to actually empower the average Nigerian with information and educate them about what capacity we have in terms of the availability of service, especially complex healthcare services. Of course, that's where neurosurgery falls under, isn't it? To actually educate them and let them know. Now, the old school style of doing things in terms of trying to actually inform people was actually going to conferences, publishing things in peer-reviewed journals and stuff like that. I'm not sure the average Nigerian is going to come to your conferences, or the average Nigerian is going to read your peer-reviewed journals, okay? So what that meant for me, I thought about it, I said, no, I think we need to be a little bit innovative, okay? Now, one of the other major problems we had on ground in Nigeria was that the Medical and Dental Council of Nigeria, which regulates doctors and dentists in Nigeria, there's a clear statute there that talks about the issue of not advertising self, okay? They frown on it a lot, you know, so not advertising self. So you had people who probably had some level of service that they could offer, but people didn't know about it, and they were like, hey, we can't put this service out so they don't think that we're advertising. So, but I actually sat and actually read that document, okay, that talks about, it's about the code of medical ethics. That talks about the issue of self-advertising and all that, okay? I'm not interested in advertising myself, but I'm interested in empowering the average Nigerian with information and letting them know what capacities we have, and then slowly building up, at least even in your own small enclave, building up a team and stuff like that. And hopefully that might be, like a sample of something that you can actually expand on in the future. And so I thought, how do we actually pull this word out there? I said, okay, we do have social media, isn't it? We have social media and stuff. So the key thing is that, and that's one thing, Ulrich, I'm extremely passionate about empowering Nigerians with information. Extremely passionate. That's why now and again you see me I'm either on radio or national TV talking, and I talk about all these issues. So I thought, how do we do this? So the first thing I thought about, okay, pictures, videos. Let's start doing videos. Let's start doing videos of the things that we're going. And if anybody who wants to watch the videos that we put, you can actually use my name, Douglas Okor, and go on YouTube and watch those videos. Okay. And so we started showing. First of all, when I got back to Nigeria, my colleague, my senior colleague, who actually trained me in the UK as well, he had defaulted to doing more spinal cases, okay? Because he had some issues. First of all, he went to the teaching, the government teaching tertiary hospital in Abuja there, and then he had some issues. And then at some point he was with another of our colleagues, and then he now established his own place called Spine Fixed in Abuja. And then so he was now providing service for just more spinal patients, okay, providing spine care and all that. And he did a fantastic job in terms of health promotion, in terms of the advocacy, in terms of showing the availability of such services, and actually improving the standard and raising the bar for providing spinal services. And of course, for anybody who doesn't know, it's easier to look after patients who have spinal problems than patients who have complex brain problems. Hope everybody knows that it's much easier. Okay, and so he now defaulted because of all the issues that he had been through to actually doing that. Okay, so by the time I came on ground, I was like, wow, you've done. I joined him in August 2016, and then I was like, wow, you have done a great job here, really fantastic job. So by now told him, I said, now it is time to actually now move higher. Okay, so for example, in Abuja, there are two names I can call in Abuja. Biodo Ogumbo is his name, the president of the individual I'm talking about now. And then the other name is Charles Ugwai. Okay, so these two chaps, they had actually done lots of work in terms of trying to build out some level of service of neurosurgery in Abuja. Abuja is actually the capital of Nigeria. So they have done some good work in terms of trying to actually build the service. But by the time I came on board and sort of joined them, and I told them that, especially Dr. Ogumbo, I told them that, hey, it is now time for us to move to the next level. Okay, the respect of any neurosurgeon, okay, actually comes from doing complex brain cases. Okay, orthopedic surgeons also do spinal cases. Okay, and they're actually very good at it. They also do spinal cases as well. And so my thinking was that, hey, we now need, if my vision of actually making Nigeria, Abuja and Lagos the hub for medical tourism in places like Central Africa or West Africa, if that dream is to come true, then we now have to start moving upwards in terms of actually trying to provide that kind of service of complex brain surgery. Okay, so that was what I told you. And then slowly he now evolved and he now changed from spine fixed in Abuja to brain and spine surgery consulting. Okay, and at that point, I'm really grateful to someone like Charles Ugwai, because Charles Ugwai, at that point, we're doing more spinal cases. So I started getting scared. My subspecialty training was in things like neurovascular, clipping aneurysms, doing very complex brain tumors and stuff, skull base and all that. So this was me in Nigeria now doing more fixations and spine stuff, and I'm like, oh my God, I hope I don't lose those micro neurosurgical skills that I learned during my training. And then someone like Charles Ugwai now offered that opportunity for me to start working with him. And then we now started doing some complex brain cases. I told you, one of the things with my personality is that I'm like this very party guy, you understand? Looks like a carefree person, always wearing jeans, wearing cowboy boots and stuff like that. So the first thing that happened when I got to Nigeria, I was like, are you sure this is a neurosurgeon? He looks so young. That's another thing. In places like Nigeria and Africa, we are very, we're very ageist. Do you understand? Most people, most patients and family members, when they see me, the first thing they ask me, oh, sorry, but how old are you? Are you sure you're a neurosurgeon? You look too young to be a neurosurgeon. Guess what? I'm 44 this year. My daughter is 17 years old. I'm not that young. I'm even older than the Prime Minister of France. So please, Nigerians, Africans, young people can do great stuff. You don't have to be wearing suit and wear what we call like baga in Nigeria to actually have the proficiency and the competence and the experience to actually deliver complex stuff. Okay, so like I said, so Charles Ugwai now created the opportunity, and then when I started working with Charles and doing stuff with Charles, we're now clipping aneurysms, doing complex brain tumors, doing transfemoral endoscopically and stuff like that. And the guys who were working with us were like, wow. You mean we can actually do these things in Nigeria? And there's usually one thing I hear in Nigeria where people say, oh, we did the surgery was successful, but the patient is dead. And I'm like, I don't understand. How can the surgery be successful when the patient is dead? What does that mean? So the success for a surgery is actually a patient coming in, being managed properly pre-operatively, doing the operative thing, intra-op, and managing the patient properly post-operatively, having the capacity and the team to actually manage. Because one of the things we fall down very badly, now we fall down really badly on in a place like Nigeria and other African countries, is the post-op care, the capacity for that post-op care. Okay? It's really, really sad. Going back to the issue of the human resource for health again, I keep telling people that, hey, I can tell anybody that cares to listen that, it takes more than facilities, equipment, and technology to deliver care. It takes more than those things. If you do not have the human beings that are strategic enough, that are visionary enough, that are able to actually prioritize what is really, really important and put those things together, it is a waste of time. And guess what, Ulrich? That's one of the major problems we have on the ground in places like Nigeria. You see people building things. They keep building things and commissioning things that add to absolutely nothing. I can give you a very clear example. In one of the provinces, one of the regions of Nigeria called Akaiwa, it's one of the states in the southern part of Nigeria. The then governor, before the present governor, built a hospital called Ibom Specialist Hospital. Billions of naira went into that hospital. Billions. Today, nothing is coming from that hospital. Nothing at all. Because the plan of the thinking of, oh, how are we going to staff this place? What is the strategy? What is the clientele like? What patients are we looking after and stuff like that? Where are we positioned in the country in terms of flights, domestic flights and stuff like that? None of these was thought of. Of course, probably maybe it was what we call a white elephant project to actually gulp money, like happens in most African countries. Okay. So millions went into that place. But guess what? One of the ways I work now is we have a private hospital, really cute small place. Okay, we've designed a theater. I don't know if anybody has watched any of my videos. We designed a theater that has the basic tools for providing complex neurosurgical care. Just the basic. We probably don't have things like neural navigation systems and stuff like that. Okay, but the basic things: high-speed drills, operating microscope, C-arms. You understand? All our tractor systems, all the fork and knife stuff that we actually need to provide this care, and ICU next door in this small place. Okay. Now, this small place does not have all the other people in the team that you need. Okay. It doesn't have anesthetists, the physicians. If you need an ophthalmologist, it doesn't have this place. But there's another hospital. Okay. That was previously owned by the government, or is still owned by the government, but it's now been concessioned to another private place to actually run. And when it comes to the services being provided in that place, it's definitely much better in terms of standards compared to the other general hospitals. Okay, it's not like it's a super great service. Okay, now one of the things I do is I actually combine when I provide care, especially for patients with complex care needs. Okay, I actually combine these two hospitals together. So the pre-operative care is in this public-private partnership place. Okay, they do their blood test there, they get assessed and everything, make sure that their pre-operative planning is spot on. And then they are now transferred with an ambulance on the day of surgery, or maybe the day before surgery, transferred with an ambulance to the hospital that has all this hardware and everything to actually look after them. Okay, we do the operation. The staff in that hospital have now been, they are now very well trained in terms of intraoperative care of the patient. Okay, and if you watch a few of the videos, like I said, go to YouTube, you'll see some of these things happening. And then usually, especially if it's a patient with a complex brain medical condition, we usually keep them in the ICU in that hospital, that private hospital that has the hardware and everything. Okay, we have a fantastic ICU nurse that actually looks at the patient overnight, and then overnight, if the patient is stable, we actually transfer the patient back with an ambulance and all the paraphernalia back to that public-private partnership office that has everybody there. Okay, because what happens is that in that public-private partnership hospital that has some level of service, they don't have the hardware in their theater to do these operations. Okay, and so with this is innovation, isn't it? And so I'm talking about, imagine I'm talking about a small cute hospital that has that kind of theater, and a relatively not too big hospital that has some level of capacity to actually develop post-op care. Now compare that with the IBOM specialists that I talked about, that billions of naira went into, that's not delivering anything at all. And so that tells you that you just need a little bit of thinking and a little bit of strategy in terms of how you actually do things. So that's on one side. The second thing is actually the issue of the business of healthcare as well. And with this, I'll need to actually bring in statistics to actually help us here. Okay. And of course, I'll be comparing UK and Nigeria. Most people tell me most of the time that, oh, you cannot compare UK and Nigeria. I say, oh, but I'm a scientist. Part of what we do is we actually make comparison. And the reason why it would be good to compare Democratic Republic of Congo and France, or compare Nigeria and UK, is that you want to actually move up from where you are in Democratic Congo or Nigeria. That's the reason for comparison. Okay. So in the UK has roughly about 31 neurosurgical units. Okay. The average unit covers a population of somewhere between 1 to 3 million people. Okay. UK has roughly about 650 neurosurgeons. Okay. And their population is about 65 million. Okay. Now, the average unit operates on roughly about 1,000 to 1,500 patients a year. And the average unit has roughly about 2 theater sessions every blessed day. 2 theater sessions means 2 theaters going on every day. And that does not include your emergency theater. So if a neurosurgical emergency comes through the door, there is another theater to actually deal with that. So elective cases, non-urgent cases going through 2 theaters. So that means you actually have some centers in UK that has 4 theaters running a day. So but let me just say an average of 2. So that means in a week, you're going to have roughly 10 theater sessions, isn't it? In a week. And if you now extrapolate that to a year, you're looking at what? Almost like 500 theater sessions. That is some good work going on, isn't it? So imagine so you being a trainee in that sort of system and going through all those cases and so on. You will be good. You don't have a choice. You just have to be properly trained neurosurgeon. You have lots of cases going on. Now let's compare this with Nigeria. Okay, Nigeria has a population of 200 million people. Okay, the population of fully trained neurosurgeons in Nigeria now are roughly somewhere about 90. Okay, let me use National Hospital in Abuja, for example. So National Hospital is the public hospital that has the most neurosurgical patients. You have about 3 other provinces or 4 other provinces around Abuja that do not have any neurosurgeon at all. Kogi State, Nasarawa State, Kogi State, and Niger State. They have no neurosurgeon at all. So if you add the population of those states, okay, and the population of Abuja, you're looking at something like 30 million people, if not more. Okay, and you just have 2 neurosurgeons consultant neurosurgeons in National Hospital. Okay. They have like one theater session per week, or let's say 1.5 per week. You remember I said in the UK you have an average of 2 per day. They have like 1 theater session per week, okay, and so roughly about 6 theater sessions per month, and roughly in a year they're going to have 70 or less. Okay, so when it comes to even the turnover of patients, so it tells you what the training of the average neurosurgeon is going to be like in Nigeria. So one of the major deficiencies of training in Nigeria is doing complex neurosurgical stuff. So when it comes to the simple stuff like doing boreholes for subdurals, doing craniotomies for acute subdurals, extradurals, doing simple laminectomies, doing shunts for babies who have hydrocephalus and stuff like that, that is where the training, yes, and that is almost like the average, where you can have the average level of training in Nigeria. When it comes to doing complex micro neurosurgical stuff, it is a struggle. How many neurosurgical units in Nigeria have a proper operating microscope, for example? How many of them? Okay, so these are some of the major issues. So even from the business point of view of looking at turnover, for example, you understand, it is a struggle. Of course, in terms of innovation, what can you do with innovation? One of the things you can do is that the private players who are, for example, that private hospital I talked about has a fantastic theater for doing neurosurgery and stuff like that. Just think about if there was a collaboration between that hospital and the national hospital, for example. Okay, and then that private hospital now says, oh, our markup in terms of what we are going to charge for doing surgeries in our theater, for example, we're going to significantly reduce it. It might be double of what they actually do in national hospital, but imagine the waiting list of people in the national hospital. Just imagine what the waiting list is like if you're doing just one theater session per day with that sort of population. Of course, one of the other major fundamental issues is the issue of financing, of healthcare financing. You know, in Nigeria, it is pay out of your pocket. You pay out of your pocket. So imagine, does anybody sit down in their house and say, "Oh, you know what? I'm going to keep these millions of naira for when I get my aneurysm and aneurysm ruptures to actually go to hospital." No, nobody does that. So you see a significant number of people, especially people who are poor, they run into these problems. You cannot treat them. I'm more in the private sector, and you just imagine the investment in the hardware in the place where I do all this is. Okay, and they are private people. Private people make investment. Of course, they want to make their money back, isn't it, Ulrich? They want to make their money back. So while there's availability, and I think it's a journey, while there's availability of service, those services are not accessible or affordable to the average Nigerian. But at least you start from somewhere. Let's show them you can actually make them available. And I think people like me and others like me, and because there are lots of people doing fantastic online. The problem is that they are more in the private sector, and the private sector comes with private investment that wants to make profits. Okay, and so the average Nigerian cannot actually access those services. But at least we are providing some availability. Hopefully, we'll start thinking of strategies to actually see how we can actually start pushing for accessibility and affordability.
When you said a multi-pronged approach, you weren't joking. I mean, you've tackled this from a public health sector and a business and administrative sector. And what you've spoken about business-wise is like it comes really close to some business innovations that we've seen around the world, like what we've seen with Narayana Health in India, which does Fordism in healthcare services. So Gideon was asking, well, do you think the lack of consistent operating is due to lack of theater space, supervisors, or just the patients not getting access to the care that they need?
So again, comparison. I love comparison a lot. So the neurosurgery, for example, in the UK, neurosurgery, you'll find neurosurgical units, and I'm sure most places all over the world, you find them in the tertiary hospitals, the very big hospitals, isn't it? And so if you go to the average tertiary hospital in the UK, and I'm sure it's the same in the US as well, when you go into the theaters, you find out that you have probably like, I'll give you an example, like 30 theater suites, 35 theater suites, 40 theater suites, okay? In the average teaching hospital, average tertiary hospital, in places like UK and US, like 30, 40 theater suites, okay? Now, if you come to the average tertiary hospital in Nigeria, the most you'll see is like 6, tops 8 theater suites. That's even too much. The average you'll see is like 4 theater suites in a teaching hospital. You understand? That provides care they're supposed to provide care for a population of millions of people. So, for example, in National Hospital in Abuja, okay, National Hospital, despite the fact that they don't have a trauma unit that has maybe like 1 or 2 theaters, they definitely do not have more than 8 theater suites. Top is 10 theater suites. Okay. Now remember that in that hospital, you also have cardiothoracic surgery, you have urology, you have general surgery, you have ophthalmology, you have other specialties that want to use the theater as well. So you end up getting 1 theater session a week. Again, going back to the thinking of the people who actually established that hospitals. What were they thinking in the first place? What was their strategy? What you understand? What in terms of looking at population growth, looking at what you understand how were they looking? Were they forward looking? Okay, so these are the major problems that we are having with this issue of healthcare in most African countries. The issue of planning, proper planning. Okay, so the issue of not actually having a high turnover of patients is multifactorial again. Okay, one of them I told you. You know, the inability to plan properly for the spaces. You know, in terms of the infrastructure that you're actually putting on ground to actually provide care for patients. That's number 1. Number 2, you know, access to care. More than 65% of people in Nigeria live below $2 a day. How are they going to access this care? Neurosurgical care is expensive. Please, let's not kid ourselves. Neurosurgical care is expensive everywhere in the world. Everywhere in the world. In the UK, right, they don't know what they really enjoy in what we call their national health service, where healthcare is free at the point of actually accessing it. Okay? It's a major struggle. So it's a combination of things. It's not just one thing.
Sorry. Yes, I mean, I totally agree with you. I mean, we usually say this when we talk about something being expensive, we forget about the perspective. There's always someone who has to foot the bill, and in the UK, the NHS is doing that job, footing the bill, and the taxpayer is getting the money. But unfortunately for us, it's our own patients, our brothers and sisters that have to get that money out of their pocket after living, like you said, most of them under $2 a day to try and pay for those services. I want to perhaps the last question for today, and actually it's befitting that the question is from Mr. Oshiwokunze, who's a practicing consultant neurosurgeon from the UK. He's a previous guest speaker here. So it starts by congratulating you. Fantastic talk, Mr. Okor. Very inspiring. Are there educational programs to support training for nurses in government hospitals to improve post-operative care for complex neurosurgical procedures?
So first of all, I want to say thank you to Shungu for actually joining. Shungu actually trained me. He's my boss. He trained me in Sheffield, in Royal Hallamshire in Sheffield. So Shungu is my boss. So when it comes to that sort of organized, properly, you know, thought out, organized training program for not just nurses, but other healthcare professionals that will actually help within a team to actually provide care, no, you do not have any. Okay, you don't have any organized one. So what just happens is that in your own small locale or whatever, you know, you just try and organize what you can organize. So for example, in that hospital that has the public-private partnership, one of the things I do is I do in-house training. Okay, I do in-house training for the nurses, the physiotherapists, in fact, everybody, the anesthetists. In fact, one of the things that's happened, Ulrich, is that I've actually turned to a neurocritical care specialist as well. Okay, I'm supposed to be a neurosurgeon, but I now do neurocritical care as well. Because the truth is that the guys who are on ground who work with me, it's a struggle, man. I'm pulling my hair out every time. A real struggle. You understand? Almost every day I'm fighting, Ulrich. We're almost throwing punches. It's that bad. But People ask me, okay, you know, so with all the struggles you go through in Nigeria, the difficulties, how come you're still there? There's a question of what sustains motivation, Ulrich. What sustains motivation? What sustains motivation is that when you throw in something, you put in an effort, you actually see some gains. And I've actually seen significant gains in the effort. So even when I'm tired, when I look again and I reflect, you know, I was like, it's actually, things are actually happening, you know, sir, slowly, you know, sir, things are beginning to happen. And the truth is that things will get better. It's just a matter of time. You understand? Not putting in the effort is not an option. Let me state that very clearly. It is not an option at all. And I want to thank you, Ulrich, and your team, you know, sir, for what you guys are doing with this, because the truth is that the young generation of Nigerians, of Africans, Congolese, you know, sir, people from Kenya, so they need to be motivated. They need to be inspired, because what's happening is that everybody just looks at the whole situation and say, oh, you know, so let's throw up our hands in the air and let's just give up. No, we cannot give up. We cannot give up. We cannot. In fact, the option of giving up is not even on the ground at all, despite how bad things are. You know, because there is light at the end of the tunnel. And one of the things I keep saying is that we need to keep pushing, because the Nigerian, the African patients are worth it.
Wow. I mean, if I had to summarize all that you've said, it will be a list of quotes of motivational speeches. It was so many of them, you were just dishing them out, and I think we'll probably be coming up with some little gifts with like your face and the quotes out there, and dishing them out just in the groups. Thank you so much. It's been really impressive, a different perspective. How do you get from theory to practice? And your story just is befitting. I mean, I think after this, no one here will have an excuse of, oh, it's so bad, I can't do this. Everyone knows that giving up is not an option. You have to do something. So, and wherever you are, no excuse. You have to do something, and you have to start somewhere. I think that is the big summary, but you covered everything. Thank you to everyone that attended today. You've always been fantastic. Just the fact that you're taking the time to listen to this means that you actually agree with Dr. Okor. You feel that you have to do something, and that's why you came to listen. You wanted to see how that something needs to be done. And thank you, Dr. Okor, for taking the time with us. We'll make this video available as always on YouTube. We'll share the link as well so that everyone can access them. You can share them, like them, and comment them. We hope to have you very soon, and please keep us abreast of all the innovations that you're coming up in Nigeria, because we'd like to copy them in other African countries.